Welcome back to Track 1. This is Care and Support. I want to thank Biogen for sponsoring the afternoon refreshment. My name is Robert Austria, and I will be the track host for this afternoon's sessions. I'd like to remind those of you joining remotely, welcome. It's through our platform Q Partners, through our live stream. Today, we're lucky to be joined by two very special presenters to walk us through how we can build a clinical care team. Please join me in welcoming Kelly Ranallo, the founder and president for the Turner Syndrome Global Alliance, and Jodie Vento, a genetic counselor manager at the Center for Rare Disease Therapy, Children's Hospital of Pittsburgh, UPMC.
First of all, I want to say thank you guys for coming in this afternoon. Jodie and I were just talking about what an amazing tract that Global Genes puts together every year. And so when you're looking at your bulletin going, oh my gosh, which one am I going to go to? I want to go to them all. Trust me, I feel the exact same way. So I want to say thank you to Nicole and Global Genes for inviting Jodie and I here and giving us the opportunity to talk with you guys this afternoon. So what Jodie and I were asked to speak about is building a clinical care team and why it matters. I think all of us in this room understand that when your child, yourself personally, a loved one, is diagnosed with any kind of medical condition, let alone a rare disease, it's really important on how you build that clinical team. Who is going to be caring for you? Who's going to be helping you make those hard decisions? Who's going to make sure that you don't look back later in your life and say, gosh, why didn't I know that question to ask and those pieces of it? And so that's really what we're here to talk about. And what I think is great about the fact that Nicole and Global Genes asked Jodie and I to co-present this is because I come from it from a parent perspective, and I'll tell you a little bit about my story once we get there. But Jodie comes from the organizational, so she comes from the hospital perspective. And I think any time when you're really looking at how to build a really good, sound team, it is truly about a team. And you have to be able to build that partnership, both from what the needs of you as a parent or a patient are, as well as being understanding of what is driving and what is motivating the hospitals or your doctors and the challenges that they may be facing as well. So as with most of you in the room, all of our journeys, especially if you're a patient or you're an advocate or you're an individual with a rare disease, we all start with something, right? We're all here for a reason. And so I want to give you a little history about my reason. Because one of the things I love most about being out at the Patient Summit is listening to the stories of the advocates, the parents, the individuals that are here, because everybody has such an amazing journey and such a unique journey. And I think it's really important that we take the time while we're here to learn from each other, to take our expertise, no matter where we're at in the process. Because if your child or you got diagnosed a week ago, you're going to be very different than, say, where I'm at, because my daughter was diagnosed 10 years ago. So to give you a little bit of history about how I got here, I'm going to have to take you back to Biology 101, because that's the easiest way to do it. So if you take yourself back to your high school biology class, we all know if you have an X and a Y chromosome, then you end up with you're a boy, you're a male. And if you have two X chromosomes, then you're going to end up being female or a girl. But the question that I would have, and to be honest with you, even though I was in the medical profession, what happens if you only have one X? Then what are you? So that is exactly what my daughter is. My daughter has Turner syndrome. This is a picture of her when she was 8 years old and she got diagnosed. I don't use a picture of her now, although she's 18 now, freshman in college. Mom's still trying to deal with the whole homesickness and my first baby going away to college. But I use this because it's important to understand my daughter wasn't diagnosed till she was 8. I'm sure there's many of us in this room, and maybe not in this room, but at this conference. I spent years being that mom that kept asking questions saying, I don't think something's right. What's going on? You know, use my pediatrician, and they just looked at me like I was that mom, right? That kind of crazy mom. And one of the challenges with Allie and with a lot of rare diseases is because if you look at this picture, Allie doesn't look like she has a disease or a medical condition. And unfortunately, with so many of the rare disease and rare conditions, a lot of times our kids or us as individuals, we don't look like we're sick. But the next couple slides will show you exactly how challenging Allie's life was, as well as many of yours in the room or your children's in the room. Because when we talk about Allie's care team, let me go back a little bit. I need to tell you a little bit about Turner syndrome. So Turner syndrome is when there is a deletion of that X chromosome. It affects 1 in 2,000 females, so there's actually about 80,000 women and girls and babies in the United States. Only 2% of girls with Turner syndrome make it to live birth, and they actually think that Turner syndrome accounts for about 10 to 15% of all miscarriages that happen with all pregnancies. Here's some of the common characteristic. So if you see the top characteristic is short stature, because she was a girl, that wasn't taken, in my opinion, as seriously as if it would have been one of my 2 sons when I kept saying she's really short, and they kept saying, oh, that's okay, she's petite, she's a girl. So again, even the challenging and the biases that we had just because of that she was a girl. So Allie's care team started with her pediatrician. For 8 years, we thought we had a healthy child. So we had a pediatrician, even though we asked again, are you sure, are you sure? A lot of your kids or you individuals may have started with a pediatrician, and that was the start of your care team. Unless, of course, if your child was diagnosed in utero, then it might have been a high-risk pregnancy doctor, or it might have been, if they were diagnosed right after birth, that your team may have started a little bit differently. But I think that something that's really common for a lot of us as parents is, so this was her first team member, and then for a lot of us as parents, here's our second care team member. Dr. Google, right? Because that's where we go. Because a lot of times our pediatrician doesn't have the answers. And so when we finally get a diagnosis, or maybe even before we get a diagnosis, we start searching the internet saying, I'm going to go with that mom gut feeling of what's out there and why am I seeing these symptoms and can I figure it out on my own? So unfortunately, Dr. Google ends up being a part of a lot of our care teams. But in Allie's case, this is how her medical care team went from. We went from a pediatrician, and within 6 months, this is now Allie's care team. So you can imagine how important it is for me as a parent and how difficult it was for me as a parent to figure out, first of all, how to say all those names, and then to go figure out how to even find those names and to access all of those different specialists and be told, wow, there's a 9-month waiting list to get in to see the urologist or, the behavioral health specialist. That's going to be another 12 months after that. So this is a challenge. This is a reality that we face as parents. And not only as parents, as individuals, even when we moved into our adult healthcare system, still the same challenge. So when you have a list of specialists, of which many of you sitting in this room, I know that you have at least this list, and some maybe even more, that role of creating your care team, a really comprehensive team, is really important to the success and the outcomes of your child or your loved one. So when we talk about what are the benefits, because part of our discussion was building a care team and then why does it matter? So I think, and again, any of you guys that have already started in the process of building your care team, it does matter. It matters significantly. It matters because you want to ensure that you have access to a full team of specialists. I don't know about you, but I do not want my pediatrician making recommendations about my daughter's heart condition, right? I want a cardiologist. I want the specialist. I want the person that was trained 13 years to make that decision when they're talking about that piece of it. Hopefully, if you have a really good coordinated team, or as you build your team, they're going to help you develop both a short-term and a long-term roadmap. Because for most of us, it is a lifetime that we're dealing with the challenges that our kids or our loved ones might have. Hopefully, if you have identified and you pick the right providers and you pick the right specialists, they're going to help you understand the questions to ask. It's really hard if somebody says, well, why didn't you ask that question? And I would say, I didn't know the question to ask. And so having a specialist and having care teams that can help guide you as a parent or as an individual to be able to make those educated questions, those educated asks, is going to be really important. You want to be able to reduce unnecessary duplication of testing. I don't know about you, but I do not prefer to get stuck multiple times, and my daughter certainly did not along the way. And so if you have a team that's already drawing labs and your urologist needs labs, and your endocrinologist needs labs. It would be really nice so that they could just take that one blood draw and be able to run all the labs that you need to have during that visit. The other thing that I think is important about having a comprehensive care team is it really reduces the occurrence of unknown complications and risks. My endocrinologist isn't going to understand every aspect of how Turner syndrome impacts the cardiac implications of my daughter. So making sure that your specialists have the knowledge, which again is a little bit challenging sometimes in rare disease too, is to find those specialists and find the ones that actually understand your condition. Also reduce the risk of adverse outcomes from contraindicated medications and treatments. Again, this goes across all healthcare. It doesn't matter if you have a rare disease or genetic condition, or if you're just somebody that has multiple medications you're taking or maybe some complexities. But that's an important aspect too, is making sure that there's communication between your team, if you're adding new drugs, if you're adding new treatments, so that you understand how that's going to impact all systems of your child or of your loved one. And then ensuring that there's a holistic approach to health and disease management. What I put on the slide before is your clinical, meaning your medical clinical care team. I think all of us sitting in the room would understand there's a whole nother team that I could have listed up there that talks about your educators out in the community, that talks about your social workers, talks about your genetic counselors, talks about who's helping you manage your insurance, and who's advocating for your child if you need to talk about guardianship and those pieces. What about your support and your child's support, just the social and emotional aspect of it? Your friends, your neighbors, who's going to fill in for you when you need respite care? So there's an entire team that goes outside of just the medical team that we're talking about today too. So if I have all that team, and I have found, and I've been lucky enough, and I found all my specialists, well, why do I still look like this? Because our healthcare system, unless you're really fortunate to have coordinated care or have a comprehensive care center where you kind of get one-stop shopping and you have an interdisciplinary team approach, you may still look like that, because now instead of having one person that you're communicating about your child's or your individual healthcare needs, now, as you saw previously, I now have 20. So that's 20 people that I'm trying to schedule appointments with, that I'm trying to get to talk to somebody else, that I'm trying to say, hey, have you seen the labs from over here? Well, if you haven't seen them, can I get them for you? Because our healthcare system in general is very siloed. You go and you see your cardiologist, and then you go over here, maybe on a totally separate day because you can't schedule your appointments together, so you're having to take off work, you're having to pull your child out of school, or maybe they're having to take off work, so that you can actually try to navigate the ship yourself. Which again, I don't know how many of you guys do, but that's a full-time job in and of itself, let alone trying to balance having a job, having 3 or 4 other kids, having a husband, having friends, having family, all of those other challenges, just day-to-day life challenges. So even when you do find your good care team and you're lucky enough to get in with all those specialists and you're like, okay, I'm there, then this is still the reality of so many of our families, especially families in the rare disease, because it's not unlikely that the world best cardiologist in your child's condition does not live in your hometown. And so now not only are you trying to coordinate care, but you're trying to figure out, how do I get, let's say I live in Kansas City, how do I get from Kansas City, and I've got to fly to Cincinnati because that's where my cardiologist is, and then my neurologist is out at CHOP in Philadelphia, and my orthopedic that did her foot surgery was in Boston and now is in Florida. And so you find yourself trying to figure out, how do I coordinate that care, and how do I do it with medical record systems that don't talk to each other? And so the second part of our conversation, and I think where Jodie and I really fit together and we believe honestly is part of the discussion is, absolutely, you need to make sure you start that step of creating your care team and your clinical care team. But I think one of the bigger challenges, and one of the challenges that I'd put towards you, and more so not towards you individually, but to our healthcare community, is that I am a strong believer in the development of coordinated care centers for specific diseases and conditions. There's a lot of statistics that show out there that when you receive care, or your child or you as an individual receive care in a coordinated care center where the care is coordinated, your team is communicating, that you have better outcomes and longevity of life. They've shown that again and again in cystic fibrosis is probably the best example of a disease state, a rare disease, that has been very strong advocates for creating centers of excellence, as well as the cancer industry. So we in Turner syndrome, we know each hospital is a little bit different, right? My hospital in Kansas City, we were just talking about it at lunch, we have 17 pediatric endocrinologists at our hospital. Omaha, which is in Nebraska, they have one for the entire state. And so how they build that comprehensive care model might be a little bit different based on the resources that you have as an organization. But the basics of each of that care model, we believe as parents in our organization should incorporate at least these components. The ability to network it with other families and walk in their shoes, somebody that you can connect with, somebody that you can ask those hard non-medical questions to of like, so where do you buy those bigger shoes because their feet swell? Or, what did you do when she started getting bullying at school? Or I can't get my school to do an IEP or a 504 plan. Those kind of questions. We also believe strongly that comprehensive care model, not just that we have all of our specialists, but that they coordinate that care for us. So in our clinic in Kansas City, we now have all of our visits coordinated on one day. So when our families come in from out of state or even our local families, they get to see all of their specialists that they need to see during that one visit. And then that allows the specialist, if there's some concerns specific to that individual girl, it gives them that opportunity to talk that day. And the most important, because I think this is a place where we lack across the United States, is the development of a good transition plan, right? We've got amazing services in our pediatric model, but at 18, what does that look like after that? Can we find those specialists that understand the disease state? How do we get her transitioned over there? Can she transition by herself? My daughter, probably yes. For many of us in a room, maybe your child isn't going to be able to independently transition. And so how do you do that? And how do you transition your health care, your insurance, and those pieces of it? So over the last, I'd say about 10 years, we've really spent my personal time and our time in Kansas City advocating for the development of these clinics. And tomorrow, if you guys are interested in talking about the details of how to start that and how to build a coordinated care center for your child for the disease state that you may be here representing, we're doing a how-to breakout section tomorrow that will go into the details of how that is. But over those years, we now have 26 Turner syndrome programs across the United States. Still not enough, especially if you live up in North Dakota and Montana. You're still traveling pretty far to be able to access one of those resources. But our goal as an organization is to make sure that every family has an access to a coordinated care center within 3-mile radius. The reason why, again, I think that Nicole invited Jodie and I and paired us up as speakers is because, of course, as parents, this is what we wanted, right? I mean, we all dream of having that one-stop shopping, coordinated care. We've actually incorporated a little bit of fun. So when our girls come to clinic, they get a pink party. So they get their hair and nails done, and our community has so embraced it that last time they all walked away with a brand new American Girl doll because some founder loves our little girl. So it's a great networking. Our little girls can't wait to go to the doctor. They absolutely love going to the doctor. Our vision in Kansas City is to make that even bigger through a project we call Rare KC, and so that we can develop a center of excellence so it doesn't matter what your disease state is, you will have that same access to the same coordinated care no matter what the diagnosis that you get. But that diagnosis and that ability to build that bigger vision really comes from a partnership. As a parent, I can say everything I want. You can sit, or as an individual in this room, and say, yep, that's what I want. Kelly said I can have it. I'm going out tomorrow. I'm going to knock on my administration, my hospital door, and I say, hey, I want one of these. But that's not how it works. It's about building a true partnership and a collaboration. And you have to understand, we know what drives us. We know what's important to us. But what you need to hear and what Jodie's here to talk to you about is how does it look like from the other side? How does it look like from our healthcare organizations? So I'm going to turn it over to Jodie.
Hi, good afternoon, everyone. Can you hear me okay? Thank you, Kelly. I think that was a great segue into what I'm going to talk about today. So I'm a genetic counselor by training, so I always say I'm in the business of the rare. I don't see patients or I don't work with families that don't have rare diseases. Everything that I see is rare. And so I want to talk a little bit about my experience in the hospital that I work in, which is Children's Hospital of Pittsburgh, and the center that we created I guess about 3 years ago now, so it's still sort of in a growth stage, but it's called the Center for Rare Disease Therapy. And what I want to talk a little bit about is both the background of why we created this center, what some of our goals are, and what we've learned along the way. For me, working with patients, I've worked in pediatrics my whole career, having a center that focuses on children and some adults with rare diseases was like a dream come true for me, because everything that I experienced in my early career was very much what Kelly explained, siloed approaches to different specialists, not communicating, not coordinating care, and I saw that how hard that was on families. And so this was really exciting to be a part of the development of a new approach. And so what I sort of challenge you to think about as I talk is how some of the things that I'm talking about can apply to your setting. So maybe you are here representing a condition where you know 20 other families in your metropolitan area that have the same condition. Maybe you know one other family that you met on social media that lives across the world. You have an ultra-rare condition that you're representing. There's a lot of principles that are similar among rare diseases that can be used together to think about a novel approach for how to best care for everybody. So several years ago, our hospital did a needs assessment as part of their strategic planning. A lot of hospitals do this, sort of our roadmap for the next 10 or 15 years. And one of the things that we noted was that rare diseases are, and everybody in this room probably knows this, but are currently underserved in large medical systems. And the need for a comprehensive rare disease center was something that came up as part of this needs assessment. And so for us, we looked at, as a hospital, what are some of the things that are our strengths in the rare disease space. And some centers are really strong at diagnosis and genetic diagnosis, some of the undiagnosed disorder centers. And for us, that's certainly a part of what we do, but it's largely some of our innovative treatments is what we felt like was something that we were able to bring that was a little bit different. And so we decided to create this center that would focus on research, education, therapy, and patient coordination. And in the first 6 months to a year, the center was really a marketing effort of the hospital. There was not a ton of meat behind it. And so myself and medical director and our executive director, as we became parts of the operating system, we've put, like I like to say, we put the meat into the center. And so now I feel like it's more than just a pretty pamphlet, but we're actually doing things. And so we focus on a handful of different conditions. It's sort of an ever-expanding list, but they're generally pediatric metabolic conditions that we focus on. I would love this list to be sort of bigger in time, but we had to start somewhere. But one of the things that's important is some of the conditions that we see that we would sort of list under our center's umbrella, we've only seen 1 or 2 patients because it's just so rare. And so there's still a place for you if that's the type of disease that you're here representing to think about. So this is our mission and vision. So an international experts focusing on treating children with rare diseases, defined by leading standards of care, pioneering protocols, and individualized services. And this is really important because every child that comes in to see us has different needs. And so we have what we call protocols. So we have some background protocols that we've worked with our multidisciplinary team to develop. Everything from how often do you see those different specialists, and who are those identified specialists in our hospital? 2, if you are admitted to the hospital under an emergency, what sort of IV fluids are you given, and who needs to be paged? And sometimes we don't have protocols because the condition is so rare that we haven't seen it enough to create a protocol. And so coming up with either new protocols or individualized care plans is really important. So these are the core components, and I think this is one of the areas that is really translatable from a lot of different motivations that might bring you to a talk like this today. Education was really important for us because not everybody is going to be coming to Western Pennsylvania where we're located for care. So how can we share some of the expertise and the things that we've learned about some of these rare conditions? And so last year we hosted, actually it was this year, it was in February, we hosted our first conference, and it was our first go-round. I felt like a wedding planner. It was so much work, but it was really great to be able to bring together some of our experts, stream it, and share that knowledge, because to keep that knowledge under our hospital roof would be a crime. It's hard enough in the rare disease community to navigate the waters, and so I think we have a responsibility to help with education. And most physicians, healthcare professionals that you may encounter do this as part of their jobs and would be happy to come and speak at a family day or a conference or wherever you think would be most helpful. So for example, one of our metabolic geneticist has done presentations every year for our emergency department. If you're someone who carries an emergency protocol letter, you know why this is important, because you don't want to show up in an emergency room and have somebody say, what do I do with that? What is that condition? What's an emergency protocol letter? And so reaching out to some of the frontline providers is really helpful. It's also where our website and marketing efforts are important, and I've learned to take my clinical hat off and sort of embrace the importance of those things, because it really does help spread awareness. Research is so important, and it's one of the big tenets for what brought the center together. It's really hard for some of our philanthropic efforts to support one single rare disease. It's hard for our foundation, who does a lot of our fundraising for the hospital, to go out to the community, to go to donors, and to seek funding for one disease that maybe affects 3 people in Western Pennsylvania. It's much easier for them to advocate for a center for rare disease therapy, and then we can help allocate those resources to families. Collaboration is so key, and it's so broken in our healthcare system. And so coming up with good models for multidisciplinary care, forging external partnerships is really important, because there's not, even in the best hospital systems, all of the best experts in a particular disease are never going to be under that roof. And so forging those external partnerships opens the door to different research, to better patient care, and having a center that fosters that is really helpful. And then, of course, clinical care. So the first thing that I wanted when I became the manager of the center was that for every patient that called our general inquiry number, I wanted to be able to, the person that answered the phone, to know how to pronounce the disease, to at least have heard of it, to make that person feel, the family, whoever's calling, feel like we will figure things out even if we don't have the answer for you. And so we're in the process of hiring another coordinator, and in our space, we feel like a genetic counselor serves that role pretty well. We'd like to also have a nurse coordinator on board to help, but as a genetic counselor, we know a lot of, at least the rare genetic conditions. And then we've worked a lot to have some extra funding to improve access for patients that may need to travel for appointments and that sort of thing. So I think it's very essential to think about who the stakeholders are when you're thinking about creating either a center of excellence or a healthcare team. There's obvious folks like advocacy groups, patients, physician leaders, clinical staff, but there's other people within the hospital that are really important stakeholders and decision makers, like our CFO, the folks from finance, billing, our president and CEO, our marketing department. Our marketing department has been very involved and has been very, very helpful and instrumental in a number of initiatives. Governmental affairs has been really helpful in helping us to push through some bills that we feel like are really important to help lobby some of our legislators on key issues. Payers and insurance companies. I've done a number of presentations with our chief medical officer to payers and insurance companies, to their medical directors, to help bring awareness about rare diseases and the importance of genetic testing. And it's also really important to remember that success may be measured differently by all the different stakeholders. So what our physician leaders may feel like is the success of the program may be very different for families than for our president. And so thinking about all of those perspectives is really important. So if you go onto our hospital's main page, this screenshot is just sort of what rotates through. So we have our Heart Institute, our Brain Care Institute. This is for primary care and express care. And the reason I highlight these is because these are centers that serve tons of patients, right? This makes sense for a hospital. It makes sense to have a Heart Institute because there are tons of pediatric patients that need that sort of comprehensive care. What's a little harder to sell is a center for rare diseases. But this is on our webpage too, and this is on the front page. And it's been the hospital's, the hospital has been inspired to focus and put energy and resources into a center that doesn't serve nearly as many people as the other centers do. And why is that? I had a really great meeting with the president of our hospital one day, and he said to me, because I asked him that question, what's in it for a hospital to put resources into a center that doesn't serve nearly as many patients, that doesn't, frankly, make nearly as much money as a heart center or a brain care center? And he said one of his biggest motivators is physician retention and motivation. A lot of physicians find working in the rare disease space or finding a novel cure or treatment for a rare disease to be very motivating. It's not the bread and butter stuff that they see every day that keeps them going, keeps them engaged. And so for him, the idea of how this motivates our physicians is really important. Hospital reputation is important. Most hospitals are known for a thing, whether it's transplant or research or whatever. And so hospital reputation is important. Innovation, marketing opportunities. Our marketing department, as I said, has been very engaged because there's been a lot of great marketing opportunities around rare diseases, Rare Disease Day, our Rare Disease Conference. Philanthropy, as I mentioned before, and financial support. And so, hospitals think about not just how do we create a center that we can support, so how can we maintain the center, but how can we make it thrive? How can we generate revenue or a revenue stream, whether it's from philanthropy, insurance, whatever, to make the center successful in the long term. And the last point is doing the right thing. And I mean this very seriously. All of the administrators that I've spoke with, they know that it's the right thing to do. It just has to make sound sense from a logistical standpoint and from a financial standpoint for a hospital to support it. And so I want to tell you a quick story, very quick in the interest of time, about serendipity and innovation, because this is the story that has been told about why our center started. So about 12 years ago, there was a little 8-year-old girl with MSUD, which is maple syrup urine disease. It's a rare metabolic disorder. And the treatment for this metabolic disorder is generally a very, very, very strict diet. And there are times that even with the best dietary control, you can have a crisis that lands you in the hospital and can be very devastating or fatal. And so this 8-year-old girl had hypervitaminosis A. completely unrelated to her MSUD. And the elevated levels of vitamin A destroyed her liver. And so she needed a liver transplant. And we were a big transplant center. And so she had a liver transplant. Well, it turned out that liver transplant cured her MSUD. That's a whole nother hour-long talk if I could go into about why that is, but it has to do with where the metabolic pathways function. And so from this, we developed a new protocol to electively perform liver transplants on patients with MSUD. And to date, we've transplanted about 68 patients with MSUD. And there are certainly complications that come around with having a liver transplant, but they have been cured of their MSUD. And that risk that they have of going into a metabolic crisis and ending up in the hospital with very, very bad consequences. And so from this, we've learned a lot. And one of the things that we learned is that we can take the liver of somebody with MSUD and give it to somebody who does not have MSUD because the liver is healthy. And so we're now doing domino transplants with those livers. And we're considering doing living donors for the next step. So somebody with MSUD, we would be able to take a portion of a liver of a parent, family member, altruistic donor, and put that in the child with MSUD, and then take the child's liver that has MSUD and give it to somebody else, basically putting another organ into the organ pool, which is so important, especially in pediatrics. And we've used this as a template to guide how to transplant other metabolic disorders that we would have never thought about liver transplant as a cure for. So this is the kind of story that brings together a lot of different tenets about innovation, research, clinical care, multidisciplinary care, that tells the story of why it's important to pull together these resources in some sort of coordinated center. And so I'll run through this really fast, but these are the things that a hospital thinks about in looking at whether a center is successful. It's the things I work on for reports for some of our executive directors. But looking at downstream revenue, this is important for genetics departments, especially that don't generate revenue from procedures and surgeries and such. What is the downstream revenue from referrals to cardiology, rheumatology, endocrinology? Thinking about alternative funding for non-reimbursable services. So our foundation is looking at ways to help support music therapy, child life, coordination of care, because those are hard things for hospitals to financially support because they don't bring in any revenue, but they're really important. Tracking marketing, engaging families for feedback and program development. This is something I'm working really actively on because this is just so essential to doing the right thing. And then, of course, measuring how this affects outcomes. And so, lastly, just a few tips. When you're thinking about creating a center of excellence or going to your hospital or going to the administration and saying, hey, we want to build this, put a different hat on. Take your parent advocate hat off and say, how would I think about this if I was the one holding the checkbook? Or how would I think about this if I was a physician that has to see so many patients per week? Think about the other folks' perspectives. And develop short-term demonstration pilot programs. This is one of the things that has been really successful for us. Help raise money to have a coordinator that comes in and helps to coordinate clinic for a few months and see how that demonstration project can show a hospital how long-term success could be achieved if they can help to fund it. Define a center of excellence. This is really important. So the CF community does this. A lot of other communities, advocacy groups, have defined centers of excellence and what is within a center of excellence. And I can tell you, as a hospital, we make sure we check all those boxes. And so if you define what is a center of excellence for your condition, hospitals want to be able to achieve that. So that's something that you can do within your advocacy network. Find out what's happening in other centers. Be open to alternative approaches. And don't give up. You're here to learn. I think this is great. This is one of the most inspiring and information-packed conferences that I've ever been to. And so, you know, you're taking the first step to do it anyway. So I think we have 2 minutes for questions, or a few minutes maybe. Do you want to come up? Okay. Thanks.
We do have a couple of minutes for questions. Anybody have any questions?
How do you address the difference between pediatric and adult? Because pediatric tends to be much more forgiving and accommodating versus the adult, especially if it's expected for the adult, i.e. the patient, to advocate for themselves. Entirely different conversation. My experience has been it's an entirely different conversation.
Right.
Even though your kid is 18, 20, 22, when the parent is in there, because it kind of changes the level of dialogue.
Right, I absolutely agree. I think Kelly mentioned this too. I mean, this is one of the areas that we have to do better in. We care for a lot of adult patients within our hospital, only because we have the experts. And I can tell you it's just not ideal, because if that adult gets sick and needs hospitalized, they're not being hospitalized at the children's hospital. And so having those adult providers engaged. And so I don't have a perfect solution for it. I think education is really important. So grand rounds, things that sort of are not much work, but can have big impact. So having a pediatric endocrinologist that you know really well present to the adult endocrinology group about the complications associated with Turner syndrome, for example, can be really impactful. So I think education is important. I think thinking about it way before a child's 18 is also really important. So. I'll repeat it.
How does the hospital look at it in terms of customer service to their customer? And
Right.
what I'm really saying is, when I'm thinking about industry, and they're providing the service, selling the service,
Right.
there's a high degree of customer service, and ultimately, it seems to me that the burden of coordinating and informing and educating is actually being shifted away from the institution to the individual. And albeit I agree that the decision's theirs and they have to be self-advocating, but it seems an unfair expectation to think of a parent, especially a parent that doesn't have an education
Sure.
or have the means to express or communicate, or resources or
Sure.
financial capabilities to actually do what you just described on behalf of the institution.
Right, that's a really good point. I'm not that old, but when I first started in clinical care, there were so many different multidisciplinary clinics that really focused on that holistic approach. And I'll tell you that the way insurances reimburse for services make multidisciplinary clinics really hard for hospitals to support financially. It's harder to bill and generate revenue. It's harder on space, which for us, being a hospital in a metropolitan area, is really hard. And so there was a time, probably within the past 5 years, that I've seen a lot of hospitals sort of let that slip away. And from a customer service standpoint, our hospital has tried to move towards this service line approach, hence the front of our website with the Heart Care and Brain Care Institute. And so I think that hospitals, that does drive them. Many hospitals are driven by things like the US News rankings and such, and reputation and customer service is really important. And so the service line approach of offering that coordinated, holistic care, the hospitals want to do it. They just have to find a model that is sustainable financially to make it work. So within our center, if you look at our operating budget, there's not a ton of things in our operating budget. Our marketing budget's pretty big, but our operating budget is me, executive director. Everybody else that is involved in our center it's just sort of another title in their signature. So our medical directors, and they have been engaged because it's been really inspiring for them. But a lot of our budget comes from foundation and philanthropy, because it's really hard to figure out how to support the coordination. Like the coordination that I would do for a family that would come in with a rare disease could take hours or days, and none of that time is reimbursable from an insurance company. And so how does a hospital support that for a large number of patients? And so, like I said, philanthropy has been really helpful for us. Looking at the downstream revenue. So if we help coordinate a patient that comes to Children's and ends up having a bone marrow transplant, for example, we've paid for more than the coordination for the rest of the year. And so being able to track that, to share that with the hospital can help to support it. I think customer service is really important to hospitals. They just can't do it in a way that isn't financially sound. We do have a revenue metric. Some of the things I mentioned in the dashboard are some of our revenue metrics, like tracking referrals, downstream revenue, reimbursement, and such. Yeah. Yes.
Hi, yeah, you mentioned that the payers were part of your stakeholders and that you went to talk with them, or you do speak with them. What are you after when you speak with them, and what's the outcome?
So with most of my conversations with them personally have been about reimbursement for genetic testing and coverage for genetic testing. That's sort of me as a genetic counselor. And we've had immense success. It's like one of my favorite success stories. So exome sequencing, if anybody has heard that terminology in this room, it's sort of the big guns genetic test. Our approval rating for it was like 5-10% 3 years ago, and now we have like a 97% approval rate. And it's just been a lot of targeted education for the medical directors and trying to demonstrate clinical utility. I know that there's a lot of other space, like medical foods, and there's a lot of other space where partnering with payers can be really helpful. And I think that one of the things that can be very useful is identifying who your champions are. So for me, our chief medical officer is the person that interfaces with the medical directors of all of the payers in our catchment area. He goes to lunch with them, like he has the relationships with them. But he doesn't know really very much about genetics. He's brilliant, but he doesn't really know very much about genetics. So he and I have made a good team in going to present to some of these folks because he has the authority and the relationships, and I have sort of the genetics knowledge and the patient experience that has been really helpful.
That's all we have time for. Give a round of applause to Kelly and Jodie. Thank you for attending the session.